room for now, so we will go ahead and get started. Thank you everyone for joining us. Welcome to the latest Duke media briefing on the COVID-19 pandemic. I'm Greg Phillips with 𝐓𝐡𝐞 Communications. We have three Duke experts with us today to discuss the current state of vaccinations, whether enough Americans are getting vaccinated to end the pandemic, what can be done to overcome vaccine hesitancy, and what role vaccine passports could be playing as we move forward. With us today is Nita Farahany. She is a professor of both law and philosophy at Duke and founding director of Duke Science and Society. Farahany studies the ethical, legal, and social implications of emerging technologies. Also with us is 𝐓𝐡𝐞 𝐏𝐚𝐧𝐞𝐥𝐢𝐬𝐭𝐬. She is an assistant professor of research at the Global Health Institute at Duke, where, among other things, she studies the role of misinformation in driving vaccine hesitancy. And we have Dr. Emanuel Walter Jr. He is Chief Medical Officer of the Duke Human Vaccine Institute, where he directs the Vaccine and Trials Unit. He's also a professor of pediatrics at the Duke School of Medicine. Professor Walter, we'll start with you. What percentage of people need to be vaccinated in order for the vaccines to be effective at a population level? And in the US, at least, how likely do you think it is there are enough willing recipients to get us there?
Well, thanks so much, Greg, for the opportunity to talk to people today and weigh in on this. I think the best estimates from all the experts that we can see is that approximately 70 to 85% of the population needs to receive a vaccine to achieve what we think is herd protection, or I like to actually call it more community protection against infection. So that's a pretty high bar to achieve, those kind of rates, 70 to 85%. But there are other infectious diseases, for example, measles, where we actually have to achieve closer to about 95% coverage in the population. We do pretty well with that. In terms of where we are in achieving that goal, I think we've really made some substantial and incredible progress over the past several months. I think at this point, the last I looked, we have 167 million doses of vaccine administered, and about 107 million people have received a first dose. So how does that translate? About 33% of the population has received a first dose of vaccine, and actually 19% of the population now has achieved or is fully vaccinated. So that's still a pretty big gap when you're looking to try and achieve 75% coverage in the population. The good news is, I think if you look up eligible people, so that's people who are, older than 16, eligible for vaccination, older than 16 years of age, or particularly the statistic that I have is over 18. About 42% of those over 18 have received at least a single dose of vaccine. And I think the expectation that I heard reported on the news this morning is that approximately half the population that's eligible will have received a vaccine by the end of this week. So all those are really, that's really good news in terms of our reaching our goal of the 75% or so to 80% coverage in the population. So we're making some really nice progress. We still have some room to go. I think the one particular population where we've really achieved good coverage is those who are at highest risk in the oldest age group. So if you look at people who are over 65 years of age, 75% have received one dose of vaccine, and about 55% are fully vaccinated now. So I think that's really good news. The one group that I think that we really need to add into the equation to achieve community protection, or quote unquote herd immunity, are children. I think that as you all know, the clinical trials for children are well underway. Children make up about 23% of the population, or somewhere around that. So if you automatically discount vaccinating children, you're already reaching a pretty low, you're already down to about 75% or so of the population that's getting vaccinated if you don't vaccinate children. So in reaching our goal to achieve herd immunity, I think we need to consider that, vaccinating children. Now, what are the steps to doing that? We first need to make sure that the vaccine is safe and effective in that age group. So.
Sure, thank you very much, and appreciate you kind of setting up the situation there. Professor Vatuvdanavan, I'd like to move on to you. Clearly, we've made a good start, but there is, as Professor Walter just said, a large gap to get us where we need to be, and we know that there is hesitancy around vaccines in general and COVID-19 in particular. Based on your observations, is enough being done nationally and locally across the country to address hesitancy about the COVID-19 vaccines?
Yeah, thanks for the question, Greg. I will begin by noting that compared to December, when the vaccines were first approved, we have now doubled the proportion of US adults who are willing to be vaccinated. So I think that by itself is great news. We should acknowledge that a majority of the shift in willingness to be vaccinated is driven by the high efficacy of the vaccines and their safety profiles. So many people who initially wanted to wait and see how the vaccines turn out are now willing to be vaccinated. So this growth in willingness is very encouraging and a sign that the national and local strategies to boost confidence in the COVID-19 vaccines have been effective. Still, one of the biggest hurdles, as Dr. Walter mentioned, is with vaccine access and making sure that everyone who wants to get vaccinated is able to do so. So although about 60 to 65% of the US adults want the vaccine, only half have received one dose of the vaccine so far. So it is critical that the national vaccine program focus on opening up the vaccine eligibility, increasing mass vaccination sites, and increasing vaccine supply. And from prior research, we know that challenges with vaccine access and appointment scheduling can create frustrations and reduce trust in the vaccination program. So in parallel to that expansion in vaccine eligibility, we need to make sure that, again, we have the ability to provide vaccines to everybody who is eligible. So I think this is where organizing additional drive-through vaccination sites, pop-up vaccination clinics at community locations, and expanding access via pharmacies will be important. And we really need those to capitalize on people's willingness to be vaccinated. I also think that increasing access to the one-dose Johnson & Johnson vaccine would be beneficial in communities where people are more likely to experience access issues, because we know that it's oftentimes hard to come back for a second dose. So having a one-dose vaccine is really beneficial from overcoming those access hurdles. One final point I will make is about changes that we can expect to see in the profile of vaccine hesitancy moving forward. So according to the latest polls, approximately 20% of the US adult population is not planning to get vaccinated or will only get vaccinated if required. So moving forward, we probably need more individualized strategies, behavioral nudges, and proactive outreach to support vaccination decisions for these individuals. In addition, as the cases of COVID-19 reduce with increasing community immunity, we could see an increase in complacency. So that is when people think that the vaccine is no longer needed. And Dr. Walter mentioned the children who are yet to be vaccinated, and I'm particularly worried about complacency with respect to kids, because our messaging to that population so far has been about their low risk and ability to get back to school. So I think we need to start thinking about how we are going to impart confidence in vaccinations for kids. And of course, we need data that's forthcoming, but we need to start thinking about that. There is strong evidence in the literature for the use of health provider recommendation to overcome vaccine complacency and lingering issues with vaccine confidence. However, to ensure that providers can make good recommendations, they need to have appropriate resources that they can tap into. So I think we need to start working on those. And we also need to support provider time and reimbursement for vaccine counseling. So I think it's time to start thinking about those kinds of scenarios and begin setting up some of the policies and programs that will help us target some of the more hesitant people as we move forward.
Absolutely, thank you. And I appreciate you introducing the issue of access, because that's something else that we'd like to talk about today. But for now, Professor Farahany, I'd like to move on to you. As more and more people are getting vaccinated, there's been discussion of using vaccine passports as a pass for people to engage in certain activities. Companies are developing apps to do this digitally, and some airlines have said they're interested in using the tech for travel, but there's also been pushback and it's becoming a very political issue. What are some of the benefits and risks of using vaccine passports in general?
The benefits, I think, are few, but I will lay out, and I'll spend more time, I think, focusing a bit on the risks. So, obviously, people are anxious to get back to some sense of normal, post-pandemic normal. And the ability to be able to do things like participate in activities that we haven't been able to participate in fully, whether that's going to a restaurant or getting on an airplane, or even just being able to gather with other people in larger groups and in places indoors where we haven't been able to do so. People think that a vaccine passport, if they know that all of the other people who are there at one of these institutions, whether that's a concert hall or somewhere else, is vaccinated, that would give them a greater sense of security. It might lead to people being more willing to participate in a lot of these activities that they've been hesitant to do. And that could be a big boost to the economy. It could give people a sense of safety and ability to re-engage. It also originally was being discussed as a way to give people reminders, right? It's important, especially for the 2-dose regimens, that people get both doses of the vaccine, and to have something that documents when you received the first vaccine, which kind of vaccine you first received. Was it Pfizer? Was it Moderna? Was it a different kind of vaccine? Such that if you go to a different place, you get both a reminder when your second dose is due, and and you're able to share with whoever the provider is what kind of vaccine you first received to make sure that you receive the proper second dose. So I think the intuition and the drive toward getting passports is an understandable one, and the value, particularly for being able to have reminders through things like vaccine cards, is a sensible one. There are a lot of risks, though, to adopting this kind of an approach, this vaccine passport approach. So while appealing, I don't think we should rush to adopt them, and I'm not sure that we ever should. I think the moment at which it might be ethical to adopt it is the moment at which we wouldn't need them anymore. So let me just lay out what some of those potential concerns are. The first is a false sense of security. We're starting to develop data that shows that people who are vaccinated are unlikely, at least with some of the vaccines, to become infected themselves, therefore unlikely to spread it to other people. But there's still a risk that you're spreading it to other people. And so if people have the sense that if they are vaccinated and if others are vaccinated, that there's no risk of transmission, they may unwittingly start to let down their guard in ways that could be particularly dangerous, either to people who are vulnerable or, to Chip's point, to the children who are not yet vaccinated. I have 2 small children. If suddenly, because I'm vaccinated and my husband is vaccinated, we choose to participate in all of the activities that we did previously, there's still a risk that we could bring it home to our children, that we could expose them, or that in taking them with us to these different types of locations, they could be at risk. The second is an equity concern. So you've heard already about the distribution of the vaccines. We're getting there. We're doing a great job of starting to roll it out in much wider availability across the population. But notice that the way we prioritized vaccination wasn't by the people who were economically hit the hardest by the pandemic. Instead, it was the people who were the most vulnerable of serious disease or death. And that was in part because of the moment that we were in at which we needed to distribute the vaccines. If it had happened earlier, you might have had a different strategy, or if we had been able to contain the virus more, you might have had a different strategy where you would distribute it to the people who are most likely to be out and about in society and spreading it to other people. Or you might have chosen, for example, to distribute it to the people who were most economically harmed and therefore need to be able to reintegrate into the society more quickly. If we condition participation in society based on access to a vaccine passport, and we do so now at this moment when there are at least half of the US population who do not yet have access to the vaccine or who aren't fully vaccinated, then what you'll see is a widening gap. Jobs that were lost during the pandemic will go to the people who were able to gain earlier access to the vaccines. And I'll note that as part of that, the minority populations in the United States have been the hardest hit. And that's for a multitude of reasons, not the least of which is that many of them didn't have the benefit of being able to work from home or work remotely. A lot of them were essential frontline workers who were either out and being exposed to COVID, or were individuals who lost their jobs because the jobs started to shut down. Those individuals, if we start to say you can't participate in society or in these different activities, we expect to see a kind of widening gap between these individuals and a greater loss of public trust in minority populations who already are experiencing a significant amount of distrust with respect to social institutions and also public health institutions. We need to be able to continue to cultivate trust in individuals such that they want to get vaccinated, such that when it is available to them, they're able to do so. The next reason is because these are drugs that do not yet have full regulatory approval. And that's not a small point. These are drugs that have emergency use authorization. And so far, it seems like they have robust efficacy and it seems like they have robust safety. But we don't know for sure yet. I was an early participant in the Moderna study. Just yesterday, I had my 7-month follow-up visit from the vaccine. And there were a new set of questions that they were asking with respect to safety, because we're continuing to look to see, are there any safety concerns that arise when you have it distributed to a much larger population? You might start to see rare side effects as you start to expand the number of people who've taken the drug. That's important data, and that's important data that goes into full regulatory approval for a drug. I think up until we have full regulatory approval for a drug, requiring people to take it, and that's what a vaccine passport would do. It would say you cannot get onto a plane, you cannot go into a public place, you cannot go into a restaurant, you cannot necessarily even have a job for the job sites that start to require it, or you can't attend an educational institution without your vaccine passport in hand. It conditions participation on taking a drug that hasn't received full regulatory approval. And I think that essentially conscripts people to being research participants, which isn't how we run clinical trials. It isn't how we address the issue of informed consent in society. And I think it would erode public trust in the regulatory process. You see a lot of people making this kind of claim about liberty. And I would say that's an issue we can talk about, but there's a privacy concern of having non-covered entities having access to our health information and starting to say that we expand the number of people who can have direct access to our health information. So we can talk a little bit more about those privacy issues in the Q&A.
Sure, absolutely. Thank you, Professor Farahany, and thank you to all of our panelists for those comprehensive opening answers. We certainly have a lot to dig into here. At this point, we will open it up to questions. Thanks to everyone who submitted questions in advance. I'm going to start with those, but in the meantime, you can also pose questions via the Q&A window at any time. If you'd like to ask a question in person, raise your hand in Zoom and we will unmute you when your turn comes around. If you're calling in by phone, you can raise your hand by pressing *9. Thanks also to everyone watching this on YouTube. So I said we've got some questions that have come in, and Professor 𝐓𝐡𝐞, I'd like to start with you. We've had a question that asks what you're hearing about vaccine hesitancy abroad, especially in China, where some of the population may no longer see the virus as a threat, and in Africa, where people might be wary of Western powers or suffer from a lack of good information about the vaccines. Now, of course, obviously, there are huge access issues across the world too, and I know that plays into that. And so, yeah, what have you heard about that, and what are leaders in some other countries doing to incentivize vaccination, and what more needs to be done, do you think?
Yeah, Greg, I think it's an important point to discuss, because even though we are focused a lot in this conversation on vaccinations in the US, unless we can achieve widespread vaccinations and control the pandemic on a global scale, we are not going to be safe in the US, even if we have quote unquote herd immunity within the US boundaries. I think access is a big issue. According to UNICEF, over 130 countries have no access to the COVID-19 vaccine. So I think that by itself tells you how far away we are from ending this pandemic. I've also heard from colleagues in Tanzania and other places that they're seeing a surge in cases. And I think a lot of that is fueled by variants. And just general lack of testing, but they are seeing a lot more severe instances of COVID-19 in places like India. Again, so India had offered to share vaccines with other countries, but they've had to pull out of some of those agreements or reduce some of those agreements because they're seeing a surge in cases within their own boundaries. So I think there are a lot of logistical and access related challenges that play a role. I think with respect to some of the specific comments you mentioned, yes, those are pretty prevalent, and again have to do with the general mistrust of where the vaccines are coming from, who has control over the vaccines, and how willing they are to share the vaccines.
Sure, thank you. And Professor Walter, I wanted to ask you to weigh in on this question of access. As we know, as Professor 𝐓𝐡𝐞 just mentioned, there are more than 100 countries that don't have access to the vaccine. We know from the global health that the old chestnut of a vaccine, an outbreak anywhere is an outbreak everywhere. Do you think that long-term access is going to prove to be a larger issue for the world in stamping out this pandemic than hesitancy is?
I do think access is going to be a big issue, probably, and I would venture to say probably more, Greg, than hesitancy. I mean, I think there always will be vaccine hesitant people, but I worry about the access issue and the fact that one of our big drivers here, I think, in the United States and pushes to get, increased coverage here in the United States is the emergence of viral variants. And if we don't, and as I think Lavanya alluded to, if we don't get a handle on that globally, we may see the emergence of more variants, and some of them could be, more resistant to coverage by our current vaccine armamentarium that we have. So I think we do need to really make an effort to attack this on a global scale.
Thank you. And we'll return to the topic of variants in a little bit, but we've had a question come in for Professor Farahany. We've had several large states banning vaccine passports or discussing banning of vaccine passports. The question that's asked is, what does that mean for the future of that technology? And does it signal that there's already a culture war surrounding vaccines and vaccine requirements in the same way that mask wearing became a political issue? Does this, does the fuss over the furor over vaccine passports have a risk in further politicizing vaccines themselves, do you think?
Probably. I've been surprised that there have been uncomfortable bedfellows together in the opposition to vaccine passports. On the one hand, you have a lot of people who are talking about the equity issues that arise from the use of vaccine passports. And that's an issue that's a moment in time, right? Which is, if you're talking about the US population and using it only within the US, at some point, there will be widespread availability of the vaccines such that anybody who wants to gain the vaccine or anybody who wants to have the vaccine can have it, and they'll have full regulatory approval. And at that moment in time, some of the equity concerns wouldn't continue to persist. What you see instead in some places is that there are strong libertarian and conservative voices that are joining with the individuals who are opposed to it for those equity reasons, arguing that there's a liberty interest in not being required to have vaccinations. And I would say this to that, which is we have in the past and in certain contexts, whether it's in healthcare settings or in education, like for example, when my daughter went to kindergarten this year, we've required vaccination in certain contexts. And I think it's permissible for us to require vaccination in certain contexts. The mechanism by which this type of vaccine passport is rolling out is very different than how we have done it traditionally in the past. And we need to have a moment where we actually reflect on that and decide what the appropriate pathway forward is. Suddenly you have a lot of corporations who are trying to get into the game of owning different biometric information about individuals that would serve as a gateway to access and entry into different settings. And that's different in kind than we have seen with the traditional use of, the state authorized vaccination list that you give for kindergarten, or the yellow books that you have if you travel internationally for certain types of vaccines that we require in order to not bring those types of diseases back into the United States and to safeguard the population. So I think that there is a strain, a kind of political strain that is starting to emerge around a liberty interest. And then there is this other strain that's really around equity and concerns about public trust. They all share in common in opposition, just different reasons and rationales for it. And so what my hope is that it will not become a conservative versus liberal, that instead people will see that there's a lot of commonality to the concerns and it doesn't need to be politicized. We need to look at what the risks of the introduction of these vaccine passports are and think carefully about what the right approach is, the multifaceted approach to be able to reopen society safely.
Sure, absolutely. Thank you. We've got a couple of hands raised here, and so we're going to go to the first one. 𝐓𝐡𝐞 𝐏𝐚𝐧𝐞, we've unmuted you, so please go ahead and ask your question.
Thank you very much. This weekend, Dr. Michael Osterholm of the Center of Infectious Disease Research and Policy in Minnesota said that the data shows that the UK variant is more contagious, especially among, obviously we know that, but especially among children. And he said that all things that we had planned it for about kids in schools with the virus are really no longer applicable. So is he right? And what should parents think about the data that shows this variant being more contagious for children? What should they do with this information? Is it still outdated, the previous guidance on the older versions of the virus? Is it still safe to send kids to school?
Dr. Walter, would you like to tackle that one?
Yeah, thanks. So sorry. Yeah, I think the underlying, most of the information we have to date in terms of school and school attendance suggests that it is okay for children to attend school if certain precautions are in place with social distancing and masking. And I think in communities where that's been done, it's been done fairly successfully to date. I do think that the UK variant is a little bit different. We don't have as much experience here in this country with that at this point, although the evidence suggests that that's increasing. I don't know that we know for sure that should change at this point, our recommendations for school attendance. I just don't think we have any good data to say that at this point. I think we still need, if it's really important, I think, for children's well-being to attend school and to be able to attend school and do the things that they normally do for children and for parents. And I don't think that we need to rush to change things without more information at this point.
Thank you very much, Michael. I hope that answered your question. We've got some more hands raised, so we're going to move on. We have somebody with the hand raised on the CBS 17 digital desk. So you're now unmuted. If you have a question, please go ahead.
Hello, can you hear me?
Yep, we can hear you.
Oh, hi, this is Judith with CBS 17. My question is, we already, when it comes to international travel, my question is regarding passports, sorry. We already have some vaccines that are required. So what would be the difference between requiring a COVID-19 vaccine for a cruise or international travel versus the others that are already required?
So there's a few differences. One is the drugs that are included on those lists that we require for international travel have widespread availability for anybody who needs them for purposes of travel, have full regulatory approval, are used in very limited context, are not governed by third-party corporations. That is, it's not a whole bunch of corporations who are getting into the game of being able to have access to your information and being the brokers of biometric information, who are not covered entities under HIPAA, who don't have the same kind of privacy safeguards in place. And I worry that the use in a much broader context, right, to participate in any aspect of society creates all of the other concerns that I've highlighted: the equity, the distribution concerns, the issues that we don't have full regulatory approval, the privacy concerns, et cetera. But I would say it's not that we cannot require vaccination in certain contexts. We do, and we can. It's a question of whether or not these passports are appropriate to be used by society in, across the board in many different settings. And the answer, I think, right now should be no.
Okay, thank you very much for that answer, Professor Farahany. Professor Vasudeva, we've got a question for you related, and you touched upon this in your opening remarks, in terms of the things that work in vaccine hesitancy campaigns. We know that there are, especially here in the US, there are certain segments of the population, racial minorities and others, that traditionally have a lower uptake of vaccines. And we know that there are certain kinds of vaccine messages that do better at getting through to those communities. Can you talk about that a little bit and what you're seeing, whether you're seeing enough of the kind of messaging that you think we need to reach all of the communities in the US?
Yes, absolutely. And I think the interventions or the messaging strategies that have been successful have been very tailored to those communities. because I think specific concerns about how well they were represented in the clinical trial, how the data might apply to them with their increased risk for COVID-19 and so forth. So I think really the use of tailored strategies has been what's been important. But I will also mention again, it feels like we are beating this drum again and again, access is still a major issue for those communities. So even as we are implementing these tailored messaging strategies, it's very important to bring vaccines to those communities, make sure that they have access. Many of these communities are healthcare deserts, don't even have pharmacies in some cases. So we really need to think about how do we bring vaccines there.
Thank you. Thank you very much, Professor 𝐓𝐡𝐞. Professor Farahany, we're obviously getting a lot of questions about passports, and I'm wondering if it might be useful because it seems like with different states and different businesses, people are saying vaccine passport when they mean slightly different things. Do we even have an accepted definition yet? And what do you think are some of the kind of elements that are common to all of these discussions of vaccine passports that have the risks that you've been talking about?
So a vaccine passport is proof of vaccination for COVID, right? And that's the kind of most basic definition. In the beginning, some people were talking about the cards that are being distributed by the CDC or some of the manufacturers of the drugs, which were really designed to give you information about when your second dose was due, and then have that information that you could provide in settings that might require it, such as some employment settings or educational settings, a healthcare worker, for example, who might be required to have vaccination, or somebody who works in a nursing home who might be required to have vaccination. So in the beginning, it was just these cards, but I think people quickly recognized that those cards could easily be forged, that lots of people were going on to Insta and other places and posting photos of their cards with all of their data, allowing other people to quickly be able to use them. There was a black market that started to develop when there was discussion of that. There are also a number of companies that are offering to essentially serve as the intermediary to create a digital passport. And that digital passport would be a verified system that you could use, and that you could go into an establishment, and if they had set up to be able to have your DigiPass verified. And what some of them are doing is trying to address some privacy concerns, for example. So you give your information and they verify it to one of the companies. And then for one of the service providers that you go into, like a restaurant, rather than them needing to get all of the information about you, like your birth date and where you got the vaccine, et cetera, it can just verify, like, is this person vaccinated or is it not? And so that could set some privacy controls into place such that you're not having to give every piece of information about yourself to every establishment you go into, but instead you're having to give it to corporations who have started to serve in the role of this intermediary. And I would just note that a lot of people who are concerned about these DigiPasses that are developing, in part, it's because there are a lot of companies who have been trying to get into this space for a while. That is to move a lot of our biometric information into digital passes and to move us away from things like identification cards and instead have these third-party service kind of brokers of information. And there's real questions about privacy and surveillance that we need to examine about what's the best way, if we do ever want to move into that realm, to set those up. And setting them up in emergency circumstances like we're in right now without that kind of thoughtful deliberation oftentimes leads to much more problems down the road than we would hope for. And it's hard to claw back those rights, claw back the kind of norms that we had prior to introducing that kind of a system.
Sure, that makes sense. Thank you. Pivoting now to this notion of variants that's come up. Dr. Walter, we've had some questions about variants. And obviously we're talking here about the need for vaccine penetration, but based on what we know so far about variants, what are the chances that we have to go back to square one with a new vaccine, or at least require people to get boosters as a result of variants, or just as a result of the fact that maybe the immunity doesn't last? How much do we know about that at this point?
Yeah, I think the data are still emerging. There was some recent data released from Pfizer, I think this past week, looking at some 6-month persistence data from their people enrolled in their trial, and it appears that immunity out to 6 months at least was pretty robust. I think we're still, the participants in those trials are still being followed, so they'll probably be, followed out for a period of a couple of years to look at immunity or the duration of immunity for them. I think, probably the next important time point will be looking out to about a 1-year time point to see how durable protection is for at least a year. At the same point in time, I know many of the manufacturers or several are also looking at adding potential variants to vaccine products, and are also looking at if a booster is needed, is it safe, and how well does the booster work? So all those questions are being answered at this point, or being addressed. I don't think we have the answers right at this point to say, how durable protection is beyond 6 months, and will we need to include a vaccine that has a variant strain in it? I think we still don't know that. And then will we need to boost? So all those are still questions to be determined.
Sure, absolutely. Thank you. Professor Vatuvaan, related to that, I know, as you mentioned, part of the reason for the encouraging numbers about willingness is because of the good results so far about vaccine efficacy. Are you concerned that if, because as a result of variants or other factors, that boosters are required or new vaccines are required, that could put a dent in people's trust in the vaccine just because they think, oh, well, it wasn't effective, it wasn't effective to begin with, and people would misunderstand, the science and then use that as a reason not to get vaccinated? Is that a risk?
That is a risk that we are already thinking about. In general, when you think about behaviors that you need to engage in once in a lifetime are probably the easiest to do compared to behaviors that you need to do every day or multiple times a day, right? So when you think about vaccinations, vaccines that are required once and then you're done, you're good for your lifetime, those are probably the best kinds of vaccines. If you think about the flu vaccine, which is required every year, after a while, the fatigue sets in and there are questions about vaccine efficacy, complacency, people thinking, oh, we need to do this every year, do I really need to do this? So concerns like that will show up. I think we have many lessons to learn from flu vaccination campaigns that we should start thinking about as we get more data on whether booster doses will be required, whether this is going to be a seasonal annual shot and things like that. So this is definitely a concern moving forward.
Sure, absolutely. Thank you. Professor Farahany, we've got more questions coming in on vaccine passports here. And we have a hand raised in the chat. Bill Lucia, we're now unmuted. If you have a question, please go ahead. Okay.
Sorry.
Oh, there he is.
Yeah,
no,
sorry.
Go ahead, Bill.
Yeah, so you kind of got at this talking or responding to the last question about passports the moderator raised. But I wanted to ask about, like, in New York, they've rolled out this, it's a voluntary program, pass program, an app like you described. I guess one question I have is, like, do you see the ethics around the passports as being any different when it's a sort of voluntary opt-in thing versus a mandated thing? And then I guess a second question I have is, in terms of, like, the stuff around corporations trying to get into the game of, like, controlling biometric data, could you, like, talk a little more about how that slippery slope could work? Because, like, it seems some people might look at this and say, like, this is a very isolated circumstance. It's just this one piece of information people are handing over about, their vaccine status, and, where could that go from here?
Sure, those are good questions. So on the voluntariness, I think they're all relatively introduced in a kind of voluntary sense. That is, you don't have to participate and you can stay home, and you don't have to go to a restaurant, and you don't have to work, and you don't have to go to school. That's sort of how people frame this kind of voluntariness argument. And that's not really voluntary, right? I mean, if the people who accept the passport condition your participation on you having the passport, whether that's explicit coercion or implicit coercion, it is not voluntary in the sense of what we think of as a truly free and autonomous choice. And so I think it's good if they're going to adopt it, they need to have it be voluntary. I also think it's good that there is the option in the New York system that it isn't just a vaccine. You could also test negative. And if we had rapid, point of care, saliva-based testing, antigen testing, something that was really simple to administer, that could be an alternative and one of many different strategies that we might implement. So I think that's good too, in that it isn't vaccine or nothing. But I don't consider that to be a truly voluntary system, particularly given the number of institutions that are looking at it as being a condition of entry. It still raises all of the same concerns that I've raised already, so I won't reiterate them here, but equity, distribution, public trust, full regulatory approval of the drugs. With respect to what the slippery slope is, so I've actually been looking at this issue for a while, because well before COVID, there was a pretty robust discussion, particularly in the immigration context, about companies trying to develop a DigiPass, where instead of having papers that a refugee might need in order to cross a border, that they would instead have a DigiPass that would have all of their biometric information, and a third-party company could serve in that sort of identity verification mode. And this has been a real challenge vis-a-vis governments who have traditionally served in the verification mode rather than these third-party companies. And so there had been some tension, but some discussion about this developing. And part of the idea was, especially in places where people wouldn't have access to their papers or their actual passports would be taken away from them, if there was a way for border patrols to be able to verify identity of individuals through these DigiPasses, whether that's iris scans or other kinds of information, DNA, other things that you could use for identity verification, that could be a valuable tool. And there's been some pilots of this that have already been done. And then some of the other companies were really interested in expanding that out into the United States and other places. So instead of going into a bar and giving your ID over, you would have a DigiPass that would be administered by, Microsoft or IBM or Google or one of these other companies. And for the places that have it, you would verify your birth date. Yes, I'm legal to drink. And the idea would be to expand outward and outward all of the kind of basic identity verifications that we do, rather than needing a key card for me to enter into a building at Duke. I'd have a DigiPass that would verify my actual identity through biometric information. So there's actually a lot of this has been happening, and people have been starting to develop this over time, corporations in particular, but it hasn't really taken off yet. And I think this is the gateway, which is when people are comfortable having their vaccination status in one of these, and then it gets expanded out to include your other information in order to gain access and entry. And all of the companies and all of the restaurants set up the systems to be able to use the DigiPass verification. I think we start going in the direction of giving a lot more biometric information for identity verification and other kinds of verification than we have in the past.
Thank you very much for that comprehensive answer. We're here to talk about vaccines. We're also talking about digital dystopia. It seems like there's no place that the pandemic doesn't reach. Dr. Walter, I'd like to come back to you. You mentioned in your opening answer that the estimate was that we would need 75 to 80% penetration of the vaccine to provide the kind of community protection you're talking about. We know that we get vaccinated to protect ourselves, our loved ones, and more specifically, those people who can't take the vaccine for reasons of compromised immune system. But one of the questions that I'm seeing a lot is, do we know the percentage of the population that simply medically can't get the vaccine and require the protection of everybody else in order to be safe from the pandemic?
At this point, that's a really good question. And at this point, there's really very few absolute contraindications to getting a vaccine. The only thing that would really contraindicate anyone from getting a vaccine, first, you have to be of the right age for which it's indicated. And then the only medical contraindication is if there's an allergy to the vaccine. So if you had a prior dose of vaccine and had a severe allergic reaction, then it would be not recommended to get a second dose. Or if you had an known severe allergic reaction to a vaccine component. Those are really the only reasons at this point someone should not get vaccinated. So unlike some other vaccines where, for example, live virus vaccines, there are certain groups that should not get those vaccines. These vaccines really are pretty available for use in most of the population.
The only thing I will add to that as an example is the measles vaccine, for example, is due or is recommended for kids at 12 months of age. It can be given as early as 9 months, but there are kids who are between 0 and 9 months of age who are not eligible for the vaccine, right? So the reason why we recommend everybody who can get the vaccine is to protect that cohort of kids. And my understanding is that the current trials for COVID-19 vaccines are planned up until like the 6-month period. So there might still be a group of kids who are between birth and 6 months who may not be eligible for the vaccine anytime soon.
I think, if you go on other vaccines which are somewhat comparable, if you look at influenza, for example, the age for recommendation for a flu vaccine starts at 6 months. In fact, many of those vaccines have been studied at younger ages as well. The current thought is, however, that we vaccinate moms during pregnancy for example, for influenza, which usually protects children either from antibodies that they receive from their mother that are passed through the placenta, or potentially in breast milk for breastfeeding moms that help to protect the baby from infection. So I think the thinking potentially is similar, that COVID vaccines, by vaccinating during pregnancy, provide protection, hopefully, to young infants, at least for the first few months of life. There may be a little bit of gap in that, those later months, but you should get some protection from the mom.
Okay, thank you both for that. And Professor Vasudhavan, I was going to come to you with a couple of the points that Professor Walter made. Number one, about how there are probably less people in terms of the adult population who would be at risk from a COVID vaccine. And also that obviously there are babies under a certain age that couldn't get it. Do you think those two things could both be components of a successful campaign to overcome vaccine hesitancy? Number one, you're at less risk from this, you as an adult, than you might be from other previous vaccines because it doesn't have that live virus element. And number two, a reason to get this vaccine is to protect defenseless babies who can't yet get it themselves. Are those kind of messages, do they tend to work, or can they be counterproductive in vaccine campaigns?
Yeah, those kinds of messaging have been used in the past, but even when you look at maternal vaccination rates, they are not where we want them to be. So we always talk about the benefits of vaccinations during pregnancy because they protect your child soon after birth, before your child himself or herself can get vaccinated. But we've still not been able to drive up the vaccination rates in those populations to where we would want them to be. I think COVID-19 may be slightly a different scenario just because of the scope of the pandemic and the intense scrutiny that has been placed on the vaccines and the disease. But I still think that we are not probably going to get all the way with the type of messaging that talks about protecting vulnerable populations.
Sure, thank you. And an associated question. I know that a lot of your work, understandably, in the past has surrounded flu vaccines because that's a huge annual effort to get people vaccinated. It seems the early data suggests that this year's flu season hasn't been as severe as years past because people are isolating, people are wearing masks. Obviously, that's great, but does that also create further risk, as you've mentioned, where people aren't necessarily taking the flu vaccine as seriously because it's something they have to get done every year and it requires kind of more effort? When we have a comparatively mild flu season, is there a concern that next year people will be like, oh, well, flu, that's an old thing. That's not a thing anymore. Is that something that's on the horizon for people such as yourself studying vaccine hesitancy?
Yeah, I think it's something that we need to keep in mind. I think with flu, there are a very distinct set of concerns that come up. And the fact that there has to be a new vaccine developed each year, depending on which flu strains are circulated, and then the efficacy of the vaccine may vary depending on how well our prediction works in terms of the circulating strains. I think that by itself is a big reason why people choose not to get the vaccine. And then there are all these myths about, you get the flu from the flu vaccine, and we are hearing similar stories with COVID-19. But yes, I do worry that, with lower flu circulation, that we might be adding additional reasons for people to not get vaccinated. But I think it's not something that we should take for granted now that we are reopening businesses, schools, and we are not as isolated as we were last fall. I think there's a really good chance that flu may make a comeback.
I just want to
go ahead.
Yeah, I just want to add to what Lavanya said about flu. Flu is always a challenge. I think it's always kind of out there and unknown. Guaranteed it will be back. Whether, and I don't think we really clearly know why we didn't have much flu this year. I think that's still a little unclear to people, why we didn't see it. Was it masking? Was it social isolation and distancing that led to that? That may have helped. But there also sometimes seems to be this phenomenon of interference when you have a predominant virus circulating in a population that for some reason you don't see the appearance of other viruses. I think as we see more control for COVID, we certainly are likely to see flu emerge again, and likely in the next season. And if it co-circulates with COVID, I think there's potential for problems for medical personnel trying to distinguish between COVID and flu illness, and to rapidly diagnose because they can appear somewhat similar clinically. And also then, the effects of having a COVID plus flu, and if they peak at the same time, could inundate hospitals and the healthcare system. So I think for those very reasons, we still need to strongly encourage that, even though we didn't see flu this year, that everybody in this coming fall and this coming season get a flu vaccine again. So.
Thank you both. And perhaps, who knows, maybe one legacy of the pandemic will be that people are reminded that vaccines are extremely important. We're going to be wrapping up here shortly, but Professor Farahany, I wanted to come back to you. One of the kind of thorniest issues that we've tackled here is this notion of what's voluntary, and a notion of requiring vaccination or proof of vaccination in some contexts makes sense, whereas in others it doesn't. So what I wanted to ask you was that we know that, for example, now most school systems require vaccination records before a kid starts school, and everybody is okay with that. Is there a danger, though, that as those records become more digital, that we are creating the kind of digital passport that you've expressed concern about that could follow us into adulthood? How do we resolve the tension between requiring children to get vaccinated because that has successfully stamped out countless terrible diseases, and protecting people's personal privacy as they get older?
I think part of the question is who administers it. Right, so identity and health information, the way we have traditionally administered, vaccinations. Like I take my daughter to her primary care physician. She receives her vaccination. It's in a state database for what the vaccination records are, and then there is an official document that is printed or could be sent digitally even in the future. North Carolina isn't that sophisticated in that way of sending it to all of the schools, but then I can take it directly, provide it to the school. It's not being administered by Google or Microsoft or IBM, and it doesn't come along with a whole bunch of other information that isn't relevant for the school to have access to or others to have access to. So it's not just whether or not we have certain information that is stored and shared with others. It's what's the context in which we're sharing, who has access to it, what are the data protections that are in place to safeguard and secure you from unnecessary use or misuse of that information. And then again, it's about, it's not about saying that there are certain conditions that we can't apply in certain contexts either. It's okay to have childhood vaccinations as a requirement for students to attend school. It's not okay, I don't think, to have drugs that don't have regulatory approval be on that list of requirements for children to have before they go to school. So it's a complex set of issues. I think we haven't gotten anywhere close to figuring it out yet. What I would caution is, in cases of emergencies or in moments of crises are the times when we give up the most rights, and then we can never ratchet them back. We see that post 9/11, where we had a significant surveillance state that was established and has just expanded. It hasn't decreased. And I think if we start to include within that surveillance state a lot of different corporations who have access to our information, who we have to give access to our information to without limiting principles about their use and their collection and their sharing, then I think we introduce a new layer to the surveillance state that later, after the pandemic has hopefully resolved, we will regret because we can't ratchet it back.
Sure, absolutely. Thank you. And then, of course, in addition to concerns about state surveillance, here we are handing everything about us over to corporations at the same time, willingly. But that's 21st century life for all of us. I think that's a good place to leave it. We've certainly covered a lot today. We will call it there. Thank you, everyone, for joining us. Thanks to our panelists, Nita Farahany, Lavanya Vasudevan, and Chip Walter for sharing your perspectives. If you'd like to be notified about upcoming briefings, please email dukenews@duke.edu, or if you're watching YouTube, just like and subscribe. In the meantime, let's not be complacent. Let's wear masks and distance, and certainly get vaccinated when our turn comes around, but be wary of telling every corporation on the planet that we did it. Thank you very much for joining us. Everybody have a great day, and please stay safe.